they have squint much more commonly than seen in normal children. Positive family history is almost like it's the incident. Almost 50% of the squint cases have a positive family history. So to elicit a family history is also very important. Medical history sometimes is important, as I told you about some underlying neurological causes, like even we have had children with abnormal malformation or many of the neurological conditions where they present, even convulsions. Children with a history of fits, they present to us with squint. And precipitating factors like recent history of fall, recent history of fever are all very important. Onset of squint, the history of knowing about the onset is important, because any acute onset squint should be investigated. That is the rule. Any squint which is of acute onset should be investigated. That is the golden rule. And the duration, of course, as we all know, the squint usually starts between the ages of 2 to 3 years. That's how it is. The majority of squints, that is the age of starting between 2 years and 3 years. And the pattern of deviation, that's what I said. Whether the child is having squint constantly, is the child having squint all the time, or is the child having squint only occasionally or intermittently? Is the child able to recover very quickly? Is it deviated inwards? Are the eyes deviated outwards? These are the few things we need to ask the parents. And of course, the history of any previous surgeries, previous use of glasses or occlusion is also very important. The next thing, quickly we need to, I'll just quickly brush through. We need to assess the visual acuity, look at the head position or facial symmetry. As you can see in this picture, facial asymmetry gives it can be associated with both true squints and pseudo squints. And then we do a measurement of the deviation, we do a motor and sensory evaluation, we look at the ocular movements, we do a cycloplegic refraction and a dilated fundus examination as a preliminary workup. The single most important assessment in a child, irrespective of whether the child has squint or not, is assessment of visual acuity. If it's a school-going child, a verbal child who can speak well, we have absolutely no issue. We have plenty of charts, Snellen's chart, number chart, letter charts, alphabets, all languages, no issues at all. If the child is not very cooperative, we can go ahead with some picture charts, or we can have charts called HOTB charts, like you have the 4 letters HOTB given in that, and then you have they can point out whether it is H, they have it in their hand. And we have similar, or we can have charts which show E or C, with which we can manage with children who are not very cooperative. But in pre-verbal children, very small children, in pre-verbal children, sometimes it's not that easy. Especially so, one thing you all need to keep in mind is, if there is diminished vision in one eye, it's very, very difficult for us to realize. Because the child having one eye, it can go undiagnosed for as many years as ever. You would all be knowing people who are in their middle ages who came to know of their defective vision or diminished vision in one eye only when they came for their driving license test, or even later for that matter. Okay, so in pre-verbal children it's very difficult, but then we have some peculiar cards, like here, as you can see in this first 2 pictures, we have a chart with one part of it is having no gratings, the other part has few lines like this. So this is based upon the principles that it's a forced preferential looking test, because the child would always prefer to look into the patterned area rather than a plain area. So we keep on changing we keep on changing the size of the gratings, and we can get a gross idea as to how much the child can see with the thinnest line the child is able to look at. And there are other, even smaller children, we can do some CAT4 drum test or O'Kane drum test, whether the child has a nystagmus, looking at the direction of the movement of the gratings on the drum. If bigger children, I'm not very sure if it's clear, we have like these cards is Cardiff acuity cards, where we have small pictures which are different in contrast sensitivity. The contrast will keep on reducing, and then the child has to match it with the one on the hand, or preferentially look into that. So we have a wide variety of tests with which we can assess the visual acuity. One commonly done is the Jeeramutai one. You can keep some, you can ask that, you can see if the child is able to pick up the Jeeramutai from your hand, because they are colored ones and they're very small, and even if they put it into their mouth, it's okay. So these are the E-charts and the picture charts. I've just shown a few pictures. But one thing, what I would like to tell you, one thing which can be very easily done in our clinic is to check if the child has central, steady, maintained fixation. That's what we write usually as CSM fixation. What we do is we show some colored object and we ask the child to move, to look into various directions. So if the child has to be comfortable, I need not be saying this to pediatricians because you know much better how to examine a child. So to the ophthalmologists who are here, I would like to say that usually they prefer colorful objects and should be sitting very comfortably. We should try not to touch them until, you know, as much as possible we try to not to touch the child, so the child will be more cooperative. And so what we do is we move this object without a sound. Like this is just, we want to assess the vision alone. But sometimes we have some toys with some sounds also, because sometimes we need to get their attention. And then we try to see that they are moving the eyes just by looking into various directions as we show them. And children are very cooperative. They do, we can get a very clear idea whether they have a central fixation, whether the fixation is steady, and if it is maintained. And sometimes we see that the fixation is not steady, like, you know, they move for some time and then we can see that the child is not able to maintain the fixation and they have nystagmus, and sometimes they don't prefer. And one thing we need to do is we need to ask the mother to cover one eye. If we cover, they get very upset. So I usually ask the mother to cover one eye and then I do the test with one eye and then I ask the mother to cover the other eye. So it's very, very important to test each eye separately. First is binocularly, then check uniocularly, because we need to detect amblyopia early. Amblyopia is something which will develop because of any reason for a poor vision in one eye, especially. Whether it could be an isometropia, that is difference in the power between the two eyes. It could be a squint where a different image is coming from a different area, or it could be a stimulus deprivation, like the case of cataract or glaucoma, congenital cataract, congenital glaucoma, the corneal opacity, or any retinal lesions. All these can cause the vision to be reduced in one eye, but we will never know if the other eye is perfectly normal. So that is the importance of closing each eye and testing separately. So what is amblyopia? It's actually a visual impairment due to abnormal visual development. That is, as we see in this picture, when both eyes show a clear image to the brain, the brain gets a full picture. But when two different images or when unclear images are brought by one eye, the brain prefers to ignore that particular image, or suppression is one method by which brain can avoid diplopia. So that what happens due to suppression is the neural pathways during the critical period. There is something called critical period, that is from the time of birth till 6 years of age, 6 to 8 years of age. So during this time, if there is any lack of clarity of vision reaching the brain due to some reason, whichever we mentioned before, the brain tries to suppress that image. The brain ignores that image and therefore uses only one eye. If there is something like a disuse atrophy is happening here, that is what we call as amblyopia, where there is no structural abnormality whatsoever, but the neural pathway has not developed properly and therefore the child develops amblyopia. And one thing is, this is a treatable or a preventable cause of visual handicap, which can go on to adulthood even. And the later we diagnose, the more difficult it is to treat. So this can always, what gives us a clue is, if there is a constant squint, if the child is always squinting with one eye and always using one eye, then we know the other eye, we know that the child probably might have a squint of the deviated, might have amblyopia of the squinted eye. And one more test, if the child doesn't have squint and if we need to identify whether the child has a poor vision in one eye, is this particular thing. We can cover one eye. either we can do a patch as shown in this picture, or we can just ask the mother to cover one eye and we see if the child is comfortable. As you can see in this picture, when the right eye is covered, the child is comfortably looking at whatever he is looking at. But when we cover the left eye, immediately the child tries to remove the cover, the child is very uncomfortable, starts crying. So that gives us a clue that the vision in the covered eye is probably not good. One more test what general doctors can easily do is what is known as a Bruckner test, where we throw light from a far distance with a distant direct thermoscope, and we can see that the brightness, that there is a difference in the brightness of image which is emanating from the eye, and that gives us a clue as to whether there's any squint, whether there's any refractive error or any abnormality with the eye. With this, we can also get an idea about the media clarity, and we can also we should check for pupillary reactions as well. So, in one thing is what we say as a mnemonic is bright is bad in Bruckner's, because everywhere brightness is good, right? But if the eye with the refractive error or eye with the squint is the eye which will be more bright, which will have a more brighter red reflex in Bruckner's test. Next thing which gives us a clue as to whether there's any squint or refractive error is an abnormal head posture, which could be a head tilt, which could be a chin up and down, or which could be a face turn, depending on the condition. And we have methods, objective and subjective methods, to measure the deviation. The first of this being the Hirschberg test, which I mentioned before. Just because it's a very easy test to be done, I'm just elaborating it. We just throw the light at about 3 centimeters and we look at the position of the corneal reflex. So if it's exactly in the center, then there's orthotropic. If it is we can roughly get an idea as to the degree of deviation as well by looking at the position of the Hirschberg reflex. So as we can see here, in the reflex, if it's at the pupillary border, as is here it is in the center, but here if it's in the pupillary border, it's roughly around 15 degrees, that is 30% diopters of squint. And here, as you can see, the one reflex is in the center, whereas the other is almost at the limbus, that is about 45 degrees or roughly about 80 to 90% of exotropia of that eye. So just to again re-emphasize how easily we can identify a pseudo squint. As we can see here, if it's a pseudo squint, the Hirschberg is exactly symmetrically placed in both corneas, whereas if it is a true squint, if the one reflex is here, another reflex will be in either near the limbus or it's anywhere not in the center. That gives us a very easy idea whether the squint is true or false. And next important test is a cover test, where we place a occluder or even a hand, a palm for that matter. Here, as you can see in this child, this eye is fixing and the left eye is deviated. What we do is we place a cover in front of the fixing eye and we see if the deviated eye is coming and taking up fixation. So that gives us a confirmatory evidence that if we see a corrective movement, then we know for sure that the child has a true heterotropia. So this is how we do the cover test. We cover the eye and we see the movement of the other eye coming and taking up fixation. When we take off the cover, in this child, as we can see that the eye which was under cover is still deviated and the other eye is continuing to fixate. So that is a much more better condition, because here there is alternating fixation. That is, the child is using both eyes equally. That is, there is no preference for one particular eye. But if you can look at the second video, you can see that when the eye is being covered, the other eye takes a fixation, but the minute the cover is removed, the eye goes and takes back fixation. So that means that the right eye has a fixation preference there. The child does not prefer to use the left eye, either because of some refractive error there or because of amblyopia. The child definitely has a poor vision in the left eye. That is what we infer from that particular test. And alternate cover test and cover uncover test we do to bring out the maximum deviation, and that can be measured by using a prism cover. We keep a prism with the apex directed towards the side of the deviation, and we do the alternate cover test and we note the deviation. We have to know one point of interest would be in Compton squints. primary and secondary deviation will be the same, whereas in paralytic squint, the secondary deviation will always be more than primary deviation. Secondary deviation is the deviation when the paralytic eye is fixing, and we are covering the normal eye because it needs more neural impulse to keep the eye, to bring the eye to focus. That is why the secondary deviation will be more. So one thing is like congruent squint, the angle of deviation will be equal in all cases, whereas in paralytic squint, the angle of deviation will differ in different gaze positions. Okay, and Grimsky test is a rough method where we can assess the degree of deviation by placing a squint and placing a prism in front of the squinted eye, and we notice the and we try to bring we use the Hirschberg corneal reflex method to assess the total amount of deviation. And next most important thing, it would be to test for ocular movements. That definitely helps us in identifying whether this is a comitant case or an incomitant, whether there is any granular paralysis or a restriction or a spasm which is involved in it. Also, we can identify whether there is any underaction of a muscle or an overaction of a muscle. One very important thing I need to stress upon is sometimes when we see that there is a limitation of movement, the eye is not moving laterally. Before we confirm, before we say that this is a case of 6 nerve palsy, let us check for the ocular movements and make sure there is no narrowing or retraction of the globe on adaptation. In that case, it's just a case of Duane syndrome where the treatment or management is totally different. And similarly, the Brown syndrome is yet another case where there is a tuck in the superior oblique tendon, and therefore the eyeball is not able to elevate when the eye is in an adducted position. It's very important to check for vergence, especially the convergence, because sometimes the mere cause for an exo deviation would be a convergence insufficiency, which can be easily helped with exercises and appropriate glasses or even prisms. Next, we go on to sensory tests. Most of them, like Bird's 4-dot test, Prabhakaran striated glasses, and after image tests are usually done to assess the sensory effect of the squint on ocular single vision is being affected by the squint, but the one which is needs emphasis is the test for stereopsis, because the three-dimensional view, the depth perception, is the third degree of binocular single vision, which is a very refined visual function which helps us in assessing the three-dimension or the depth perception, which is something which even helps us. Why we always test the 3D vision or the stereopsis by either a TNO test or a litmus test in our clinics is because that helps us in determining or helps us in deciding whether this child needs to go for surgery or not. A child with a very poor or absent stereopsis is one indication why we can take the child out for surgery. But one point which also you need to know is that it's very difficult to get back 3D vision exactly as near normal if a surgery is done after 6 months of age. So 6 months of infancy is the time when stereopsis develops. If any infantile esotropia, you need to do surgery at the earliest. Other tests like Maddox rod, Maddox wing, and synoptophore and diplopia charting and Hess chart in appropriate cases could be done. And I cannot overemphasize the importance of doing a proper refraction, especially all squint children we do. All children we do under cycloplegia, but cycloplegia is a must in squint children, because just because of the refractive error, the brain is not able to control the alignment of the eyes, and that can be the reason for the squint. And once the refractive error is corrected, the squint can be completely cured just by giving glasses. As you can see in this picture below, this child with esotropia is completely orthotropic with this corrective glasses. So we see this in accommodative esotropia, where we give maximum plus. We do atropine refraction and we give maximum hyperopic correction possible, and the child becomes ortho. And similarly, in children with intermittent exotropia or even exotropias, even if they are constant, they get much better with minus correction, myopic correction or myopic astigmatism. When we correct it, the child becomes ortho. Dilated fundus, we all do anyway. We are dilating for cycloplegic refraction. We have to do a dilated fundus. Meticulously, we look for any underlying pathology which would be the cause for a sensory squint here. It could be a macular scar, it could be an optic atrophy or an optic disc hypoplasia. Sometimes there's a child with, we should not be missing a case of retinoblastoma, which is presenting as squint. ROP, that is retinopathy of prematurity. Children with heavily lasered eyes could always have a tendency for refractive errors and squint, and we look for dark macula, which can present as a exotropia. And other investigations we do according to the etiology, or if we need to confirm on some particular condition. Just highlighting few red flags which needs prompt referral. One is abnormal red reflex. So it's very, very important to look with a direct ophthalmoscope, do a distant direct ophthalmoscopy from 25 centimeters or beyond, and look at the red reflex. If there is a difference in the red reflex between the two eyes, that needs prompt referral. And limited ocular movements shows that that some kind of cranial paralysis, and double vision, as we know, concomitant squints usually don't have double vision. So if there is diplopia, especially if it's a binocular diplopia, that needs a prompt referral. Presence of headaches, nystagmus, presence of face turn, or other neurological features always gives us a hint that there is some other underlying pathology. Also, when we look into the fundus, if there's an optic disc optic atrophy, or there's a papilledema, or an abnormal pupillary reaction, we always need to treat the child. The treatment, any squint which is present more than 3 months of age. So that goes that any squint which is present before 3 months of age, like in the newborn child, 2 months of age, 3 months of age, if the parents are very much worried, we need to tell them that the children have very poor vision, 6 by 60 or 6 by 36 vision during that stage, and they don't fix until about 4 to 6 weeks of age. So it's about 4 to 6 weeks that they start fixing at mother's face. So mother's face, when they are feeding, is so close by. That is what they are able to fix it. Even that they are not seeing very clearly. So and therefore, until and unless the child fixes the eye, it's impossible for us to comment on whether the child has squint or not. So usually, by and large, 2 to 3 months of age, only if whatever squint is seen might not be true squints, but there is a category of squint called essential infantile esotropia, which is a type of congenital large angle esotropia with cross fixation that needs immediate treatment before the age of 6 months, as soon as the child is able to withstand general anesthesia. So why do we need to treat squint? Because as I told you before, amblyopia is a very significant visual handicap which happens, which is a treatable or a preventable visual impairment if detected early. That can be prevented by properly treating the squint. Children can present with eye strain and asthenopic symptoms, eye fatigue, tiredness, not able to study properly, reduced binocular vision, affecting their scholastic performances. They can have occupational issues, like some jobs they insist on having stereopsis, 3D vision before being recruited, so that is another indication. And of course, psychosocial, as all of us know, they are stigmatized at school and there is a loss of self-esteem. So treatment includes these things. First one, as I already mentioned, glasses form the only treatment necessary in certain cases of squint, as very obvious in this picture. Exercises, like as I mentioned, in convergence insufficiency cases, we can give them CAT card exercises, convergence exercises, which would very much help to reduce their exo deviations. In children with amblyopia, we can do what is known as occlusion or penalization, by which we are forcing the brain to use the eye with the poorer vision, so that the visual pathway or the neural pathway develops at an earlier age. All of you know who this is, and she had to use these prism glasses, because prism glasses we usually prescribe whenever there's a paralytic squint, and usually Dr. Robert will be speaking about it in case of metabolic conditions like diabetes, hypertension, because of ischemic mononeuropathy. This is a self-resolving condition. We just need to give them 6 weeks to 3 months time. They will resolve completely all by themselves. So during that time, to avoid diplopia, we need to give them prisms. Sometimes in children also we might need to give them prisms to correct their face turn in children with nystagmus, if that is the cause for the face turn. Or sometimes we need to give them prisms when the deviation is less, very less, that surgery cannot be done. In those situations also it can be corrected with prisms. Next is surgery. It's an extraocular surgery where we do the surgery, either recess or resect a muscle according to the condition. And botulinum injection is another treatment which is attributed to these days for temporary control of squint. Like the effect lasts for about 6 months. So sometimes, like these paralytic cases where we don't want the contralateral muscles to go into spasm, we give them botulinum injection. So I'm just quickly going back to the first clinical scenarios. So the first one, a 2.5-year-old child brought with intermittent squint, was actually a case of exophoria or an intermittent exotropia, where the child was only squinting when the child was not concentrating. So that is a case of intermittent XT. So the treatment, sometimes we don't need to treat them at all if they have very good control, but of course we always need to check if they have any underlying refractive errors and correct them. And if it's an exo, we can always try to give them convergence exercises. The second case was a post-meningitis. The child had a fever and convulsions and all, so it was a case of post-meningitis, lateral rectus paralysis. As we all know, abducens palsy can sometimes be false localizing sign. I'm not going into much detail of the paralytic one, but needs urgent neurology consultation and imaging sometimes. Head trauma also can present with lateral rectus or even trochlear nerve paralysis. Okay. And the third one was where the mother was complaining that the eyes were not moving properly. This is actually a case of Duane's retraction syndrome. The clue is, look at the limitation of movement in when the child is looking to one side, but when looking into the other direction, this eye is not. I wanted to look at the left eye. It's not abducting, so there is a limited abduction there. But when the child is adducting, the eyeball is getting retracted. It will go in ophthalmos, it will be pulled inwards because of the co-contraction put by the medial rectus and the lateral rectus. So that gives us, sometimes there may be upshoots, downshoots, sometimes there may be face turn and all in Duane's retraction syndrome. The fourth one was a pseudo squint. Okay, the fixation develops. One thing is that the child was brought 1 month or 2 month child will be brought saying that the child has squint. So again, look at Hirschberg. So the pictures below are actually pictures of essential infantile esotropia. As you can see here, this reflex is exactly in the center, but this is not. This is at the pupillary border. So that says that this child definitely has esotropia. Even though it's 1 month or 2 month old child, this child needs attention, even this child also. But this child is definitely, we can tell them that's because of the broad nasal bridge, because of the prominent epicanthal fold, and we can just pinch them and show the parents that your child doesn't have squint, it's just a pseudo squint. But of course, we would like to reassess every 3 months and make sure that the child is not developing any squint. The next case was that of a sensory esotropia because of congenital cataract. Mother had rubella and the child had cataract. So these again, the clue is to look at the red reflex and look at a dull red reflex in this side, which gives us a clue as to some media opacity there. Sometimes we can see it as a frank white opacity in the pupillary area as a congenital cataract. Also, this is these kind of conditions can lead on to stimulus deprivation amblyopia. Usually we call it amblyopia as something which doesn't have a structural abnormality, right? But here there is a structural abnormality. Then why are we calling it amblyopia? Because even after treating the root cause, like we remove the cataract, we remove the underlying condition, but still the visual diminution persists. So that is why we call it as amblyopia, because there is abnormal development of the defective development of the neural pathway. Other conditions which can result in a amblyopia will be ptosis, congenital ptosis covering the pupillary area, any corneal, central corneal opacities, or any vitreous or retinal lesions like toxocara, etc. Okay. Okay, and the next one was an ischemic mononeuropathy. That was a fourth cranial nerve paralysis, trochlear nerve paralysis, where the person appreciates a vertical diplopia. So to avoid this vertical diplopia, the head is tilted to the opposite side. So what happens is, when you tilt the head to the same side as the lesion, or when you look at a person, the head is tilted to left. So if you tilt the head to the right side, we can easily see the hypertrophy of that particular eye, as is evident in this picture. When the person is tilting the head to the left, there's no, the eye looks ortho, but when you tilt to the other side, the right eye is becoming hyper. So that is what is causing the vertical diplopia. And very easy question to identify whether the person has a trochlear nerve palsy or not is asking, climbing downstairs, is it difficult? It gives us a clue, because it is the superior oblique is a muscle which helps us in looking down and in. Therefore, it is very essential for climbing down the stairs. Ischemic mononeuropathy can also be third nerve palsies of sixth nerve for that matter. And the last but not the least is, we need to pick up these cases. Parents might think that the squeezing of the eyes or watering or rubbing would be just casual findings, but make sure that they are getting an ophthalmic checkup so that we don't miss any refractive errors, we don't miss any squints, because squints and refractive errors can always present with all these. Having said that, I have put up a picture here of digital eye strain. Nowadays, squeezing and watering and everything would be attributed just to digital eye strain. Children are too much glued to the screens, and I would want even all general doctors and pediatricians to please emphasize children not to have screen time. Recommended screen time by American Academy is 0 to 3 years, 0 hours. Up to 3 years, 3 to 5 years is just half an hour, and 5 to 20 years is 2 hours with break every half an hour. So that is what we need to know. With humble salutes to my guru, Dr. Kenneth Wright, I wish to thank each and every one of you for this wonderful opportunity. Thank you very much. Open to questions, as I think after Dr. Robert's session we will have questions. Thank you.
Chairperson of Precise Eye Hospital, senior members of the faculty, friends and colleagues. At the outset, let me thank the organizers, especially the Precise Hospital, for giving me this wonderful opportunity. I consider it an honor being invited to give a talk. So very special thanks to the chairperson. It was a very exhaustive and in-depth talk by Dr. Anitha. I was just wondering, she was meaning this for the general doctors. So how would be fit us for ophthalmologists? So I'll be very brief so that you can cool down. Cranial nerve examination always always a nightmare during the MBBS days. Neurology examination for that matter. Some cardiology, some respiratory, okay. Neurology means headings after heading, higher mental function, cranial nerves, motor system, sensory, like that. And within that, cranial nerve means minimum 12 headings. So just to memorize that itself is a difficult thing. But then in due course, you get used to everything. And cranial nerve examination is extremely important. And there are often interface between ophthalmologists and neurologists when it comes to cranial nerve involvement. Mostly centered around optic nerve, third nerve, sixth nerve, like that. But lower cranial nerves also get caught once in a while in such interactions. So I'll just briefly brush up your whatever you have learned earlier, which you have not been using it, and one or two cases I'll touch upon. So this is the olfactory bulb and the olfactory tract. So olfactory, basically it's how to examine that I am supposed to say. So just a few points I will mention here and there. So the classical teaching is you test using certain substances which is commonly used by the patient or familiar to the patient, and it is preferably in solution so that the molecules will come out easily. The pungent items should be avoided, and each nostril should be tested separately. Olfactory problems are commonly seen consequent to ENT issues like chronic rhinitis, and then probably head injuries where these tiny rootlets are easily damaged, consequently head injury, and there can be olfactory problem. And the pandemic produced a lot of patients with olfactory damage. Some of them had recovery, and there are people without much recovery also. So that is about olfaction. So I'll move on to the optic nerve. So that's the optic chiasma, and then the optic tract, and the optic radiation. It comes to the occipital cortex. So just to show that there is something here, the lateral dentate body where there is some synapse and all. So lesion of the optic nerve can so basically from here, from the retina, anywhere there will be lesion in the optic pathway. So this picture is very familiar. It helps us to sort of identify where the lesion is. So I am not going to the details. Very commonly, so something like a hemianopia, we see patients complaining of loss of vision of one eye. So they may say there is loss of vision of the right side, but basically it may be a right hemianopia. So we just have to tell them you close each eye and see whether there is any problem. So if it's a hemianopia, then they will be confused sort of. They will close each eye and see, and some problems there in vision. But if it is just an ocular cause or an optic nerve cause prior to the chiasma, then when they close the eye, it becomes very clear. When one eye is closed, then there is a good vision. When the other eye is closed, there is a bad vision. So each eye, if they close and find, and still they are confused, then lesion may be intracranial. So in that case, it may be a case for a neurological reference. Otherwise, depending upon where the lesion is, there are different patterns, and this is all brought out by a visual field charting, and it's very, very useful in assessing the patient as well as for follow-up, especially in pituitary. So pituitary tumor comes somewhere here. So if there's a pituitary tumor, then serial charting of the visual field may help us in picking up widening or increase in size of the tumor even without doing imaging. So that is about the optic tract, radiation, etc. And this is a common situation where we get reference from the ophthalmologist. It's an optic neuritis. It's a fundus finding. So here it's the disc margin is blurred, and there is some amount of hyperemia also. So optic neuritis can be a disease confined to the optic nerve in case they will have acute onset of visual loss, and they have a good response to intravenous methylprednisolone from 3 to 5 days, and you can follow with a short taper, say over 3 weeks. At the same time, in some percentage of patients, this can be the first event of multiple sclerosis also. So optic neuritis means always it warrants further investigation towards finding out whether there's a chance of recurrence. So you may have to carefully ask about any previous history where they had acute onset of some numbness somewhere or some girdle sensation. So things which might have been just brushed aside as insignificant. When you get an optic neuritis, you may have to get into those history again. And if you get something, definitely, then they need investigation. MRI, of course, will be the first one. And you can see these well-defined ones. So they are well-defined hyperintense plaques. This is called the Dawson's fingers. And this is another plaque in the posterior fossa, in the cerebellum. So these show that it's multiple sclerosis. So they may have to go through the whole set of investigations, including CSF study, visual evoked potential, and then in many of the situations, these patients may have to be initiated on disease-modifying treatment also. So earlier, maybe 20 years back, this disease-modifying treatment was not easily available here. So even if you diagnose, there was not much which you could offer. So it was not very important. But now things have changed. And if you miss this, patient comes to you with optic neuritis and you don't investigate properly, and then they come with a hemiplegia, and then that's a very bad scene. So for all optic neuritis, it is mandatory that you should go for MRI scan. And if the MRI scan is normal, probably it can just be an optic neuritis, or it can still be an MS, which can be picked up only by further investigations like visual evoked potentials or oligochromal band, etc. We should also keep in mind that there are other conditions like vasculitis and all which can give a similar picture. Afferent pupillary dysfunction is one of the important signs here which can persist even after recovery. So when we check for the pupillary reflex, swinging from one eye to the other eye, usually when you throw eye on the pupil constricts. But in patients with optic neuritis, when you swing the light from one pupil to the other one, that pupil will react rather than constricting, and that's called afferent pupillary dysfunction. So that can be present even after recovery. So this is MRI showing the edematous optic nerve. So some of the situations, the MRI will be really helpful, not only to show the plaques, to show the cranial nerve anatomy, and to some extent the cranial nerve pathology also. So this is another very common situation. This is called papilledema. The whole of the optic disc margin is blurred, and there is hyperemia. So this is commonly seen in situations where the pressure inside the brain is increased, increased intracranial pressure. So it can be due to a structural lesion or a space occupying lesion like a tumor in the brain, or it can be consequent to some less malignant conditions like idiopathic intracranial hypertension, where the pressure is just increased but there are no tumors. So this is a situation where, especially when it's bilateral, a neurological evaluation is mandatory, and imaging also is mandatory. Just coming on after the optic nerve, this is the oculomotor nerve. So a lot of things have been already discussed as part of squint. So I'll just try to pick up some findings for you. This is the patient's looking straight. It's okay. Now here, the patient is trying to look towards the left side. Now, so that is also not showing too much of abnormality, except probably that this palpable fissure is little small when compared to this side, and there is some amount of ptosis. And here, now the patient is looking down. So this is not coming down properly as much as this is coming down. So there is some amount of a skew deviation. So there is some problem in the depression of this eyeball. Now here, the patient is looking towards the right side, and this eye is not moving properly. There is a problem with the adduction in the left eye. And here, looking up, this is not going up the way this is going. So there is a problem in elevation here, and you are seeing some red color here. Somebody other than madam want to make a guess? Okay. In fact, that is interesting because that gives an opportunity to discuss something more. So, one-and-a-half syndrome basically it's a problem with the brain stem. But we are dealing with something which is purely dealing with the nerves only. So, the basic thing in neurology will be try to explain all the findings with a single point lesion. That is the basic thing. So, here let me say, we'll just summarize. There is a problem. This dose is one important clue, and there is this eye. This is abnormal eye, and no, I just want to know which nerve is involved. That's all. Which nerve is involved? Actually, this pupil also is slightly bigger when compared to this. So, okay, I'll put it very briefly. Most of the movements of the left eye is involved. So, most of the movements will be dealt with by the third nerve. So, actually, sixth and the fourth is bad in this. We won't go into it. So, the doses as well as involvement shows that there's a third nerve involvement. And this is a confusion, bruise. This is basically a traumatic third nerve palsy. Patient had a fall and had injury. This is just to show that the MRI is now smart enough to pick up the third nerve. You can see this is the third nerve. Directly you can see the nerve. Okay, this madam I discussed in detail. Which is the nerve? This is the fourth nerve. Fourth nerve is involved. Which side? It's in the right side. Head tilts away from the side of lesion. So, right fourth nerve palsy. So, diplopia charting also confirm this. This is very, very useful. Diplopia charting as well as interpreting it. So, if you know the movements of each muscle, it's easy. But then if you have a chart like this, then this shows each pattern which muscle is involved. Then you don't have to break your head too much also. It's easy, but it's very useful. So this is basically done by covering one eye with a red glass and asking the patient to keep the eye at different positions and describing how the patient sees this red light. And it is charted out. This again, this is actually this is a very small schwannoma. It's a tumor which involves the fourth nerve. So this produces head tilt and all. Okay, which is the nerve? Oh, very good. Okay, so it's easy. When looking towards this side, it's now moving nicely. This side, this is staying back. So it's a right lateral rectus. So when there is a right lateral rectus lesion, the eye moves, the head turns towards the side of lesion. Okay, so that way also you may get a clue. Just something about ptosis. So this is how you examine. Just look for, spend at least 1 minute to see any palpebral asymmetry and resting position of upper and lower eyelids and look for ptosis. Okay, so this is normally the upper eyelid covers up to 2 millimeters of the upper part of iris and it just grazes the lower part. So what do we see here? This one is dilated.
Okay. So I was going little above. I didn't think of too many serious things. Okay. But I would say this is smaller. That's okay? Yeah, this is honors. Here's there's a doses. So even though this is larger, because there's a doses, I'll keep this as an important one. So it's a honor in the right side. Now, oh, sorry, something went. No, I just wanted to, sorry for that. So I had a patient referred to me, a 45-year-old lady with a background history of headache going on for a few years. And she was referred because she had a small palpable fissure on the right side. Okay. So when I examined, she didn't have any other focal deficits. It was just a Horner syndrome on the right side. So how do I proceed?
Denervation hypersensitivity we have to test with low
Ah.
concentration pyrotherapy.
Exactly. I don't know whether anybody is doing that. We have been reading it from MBBS days. But I don't know whether ophthalmologists don't do that. No, neurologists don't do that. Okay. What next? Sensations normal. What sensations? Everything sensations normal. Just X-ray for what? Pancreas usually produces a painful honor. So painful honor means we are worried about pancreas,
Look for brainstem lesions, posterior inferior cellular artery syndrome and all associated.
which translates into an MRI.
MRI.
Okay, anybody else? No, I was also thinking along the same direction. The only clue was that she was getting headache on and off. So does that ring a bell?
Ophthalmically migraine, arterial.
It looked like a migraine only. The headache looked like migraine. So I was thinking of ophthalmoplegic migraine, or even without ophthalmoplegia, you can have this honors as part of migraine, cluster headache, many of the short-lasting headache syndromes. So I was thinking of that. So how do I proceed? I know that the MRI is not going to help me now. None of these conditions will be picked up by the MRI.
Give migraine prophylaxis and see whether she's
That was a very good thing, but she was not getting headache during those days. It was just a honor picked up by an ophthalmologist. She was not, she didn't come to me for treatment of the headache. Okay, so I did something very simple. They had a mobile and lot of photos were there. So I asked them to pick up some photos which were 5 years old or 10 years back photos. And that was also showing this. So I stopped it there. It could be congenital or it could be part of the migraine which she was getting earlier. Migraineurs do have this very often. So, but if you look at the list of conditions producing honor, then it's a huge list. I think it's more than 100 in textbooks. So the reality will be more than 200. And if you start investigating, then there is no end to it. And lot of them are not picked up by MRIs. That's a difficult thing. Anyway, so honor, I think, if it is isolated, it's better that it's underplayed or ignored at least to some extent.
That goes to for correspondence.
Very much, very much. That's one of the situations where you have to be very careful. Two situations. One will be a dissection of ICE, internal carotid artery dissection, that's inside the cavernous sinus. Honors may be the only sign, but they will have pain. So in the background of some malignancy, some aches and pains here and there, you'll have to. So these two things you should not be missing. But otherwise, I think isolated honors, I am not too much worried about that. So coming to, this is just to touch upon what Sir said, the INO and all. There are a lot of control structures. So we have been dealing with the cranial nerves only, but there are a lot of areas in the brain which coordinates the movements between these cranial nerves, and so that we get meaningful images. But I won't go into those things. So they are all involved in various lesions of the brainstem, and knowledge of that will help us in localizing the lesion in the brainstem. So coming to the fifth nerve has a sensory part, and motor part. So sensory part is from lower part of the pons to the medulla, and the motor part is in the pons. Just get these. Okay, that's the sensory one. So when you check the sensation of the fifth nerve, you'll have to check the ophthalmic part, the maxillary part, and the mandibular part. So they will be differentially involved. So touch, pain, touch as well as pain you can check. And then the motor part is checked by asking the patient to clench the teeth and then open the mouth. So that will be for the lateral pterygoids. Clenching will be for the temporalis mostly, and then lateral movements for the pterygoids again. So that is how the motor part is tested. Not much of interface between ophthalmology and fifth nerve comes, except probably in trigeminal neuralgias and short-lasting headache syndromes, where there will be associated either visual auras or something like a honor or ophthalmoplegia. This is the seventh nerve. Okay, that's a common picture. So he has difficulty in closing the right eye, and the angle of mouth is deviated towards the left side. So for testing the seventh nerve, you ask the patient to produce wrinkles in the forehead, and wrinkles will be reduced in the right side, and ask the patient to close the eye tight on the right side, which will be difficult in the involved side, and then the angle of mouth will be deviated towards the left side. So upper part of the facial will have representation from both sides, and lower part is one. So basically, if it's a lesion at the level of the facial nerve, then whole of one half is involved. And if it's a lesion above the level of the facial nerve nucleus, so facial nerve is from the pons. So if it is from above the pons, then only the lower part will be involved. So the closing of eye will be normal, but the facial deviation will be there. So if the lesion is bilateral above the facial nerve, then how do you get it?
Spontaneous reaction, like spontaneously you ask the patient to tell a joke. Suddenly when the patient reacts.
Thank you very much. Once again, sir, took me away from what I was trying to say. So this is called emotional volitional dissociation. So that happens in intracranial lesions. So inside the brain, the fibers which move the facial muscles on command are separate from the fibers which move the facial muscles on emotional expression. So when you are smiling, there are emotional fibers which moves the facial muscles, and when you are voluntarily trying to show your teeth, it's the volitional fibers. These fibers don't go close together, they are little separated. So in a situation where you ask the patient to show the teeth, they don't do that, then you crack a joke and then they do it, then there's a dissociation. So this dissociation means that lesion is most likely inside the brain, inside the skull, mostly in the supratendoral region. So some of them can be congenital also, and rarely in temporal lobe epilepsies they can have this dissociation. So they have some localizing value, but my question was slightly different. Both sides are involved above the level of pons. So how does it look? So above the level of pons.
Forehead also will be involved.
Pardon me, sir?
The forehead also.
Exactly. So this concept. So if it's UMN, the lower part is involved, upper part is spare, and if it's if it's UMN, here it's normal and this is involved. If it is LMN, whole is involved. But this rule holds good only when it's unilateral. When it's bilateral, then it becomes difficult, because bilateral means whole of the face will be involved. Then you'll have to look for other signs like Bell's phenomena, where the eyeballs go up when you try to close the eye, or the reflexes will be sort of exaggerated. You can percuss the facial muscles and see the facial reflex. So facial reflexes will be exaggerated if it's an UMN lesion, and the Bell's phenomena will be present if it's an LMN lesion.
In MBBS, yes, how will you differentiate between bilateral UMN palsy and bilateral element.
Exactly.
That's a question.
That's a set question.
Yes.
Okay, so that is something about facial and facial in situations where the regeneration of the facial nerve is incomplete, then probably some tarsography, something may have to be done to protect the eye on a long-term basis. But otherwise, there are no facial in the neuro interface in facial nerve. So this is just to.
So one thing is sarcoidosis, facial nerve is usually involved.
Absolutely.
Clearfold syndrome. So we have chronic uveitis with sarcoid many patients.
Okay.
Anytime, we look for that.
Okay.
That can tell you that, patient can have sarcoid.
So they come with uveitis.
Element facial palsy is one clue for sarcoid when you have associated features affecting the eye.
Okay.
But you can get in Behçet's also.
Yes, no, I'm just telling you as far as eye is concerned.
Okay.
Behçet's, seventh nervous syndrome?
Yeah,
Usually it's more of CNS,
CNS.
but ANS also is possible. So coming to 8 now. So we are supposed to check the hearing. So the Rinne's, Weber and Schwaber's test using the tuning fork, and then look for nystagmus. Now this is Halpich's maneuver. This is basically done to bring out nystagmus in patients with labyrinthine vertigo. So head is turned to one side and brought down. So they get some symptoms of vertigo, and you look at the eye, you see nystagmus also. So coming down, the 9 and 10 are tested together, sort of. So palatal movements, palatal reflex, pharyngeal reflex. These are the things which are commonly checked, and the sensory part will indicate 9th nerve involvement, and the motor roughly indicates the 10th nerve involvement. And this is cranial nerve 11. So 11 has a component coming from the cervical part also. So this is tested by checking the power of the sternocleidomastoid and the trapezius. Anything seen here, abnormality?
So it's a muscle.
This side, no? Okay, so this is the muscle which is missing here. So it's a sternocleidomastoid muscle that is weak on that side. So a sternocleidomastoid muscle is checked by asking the patient to move the jaw against resistance, turn the head against resistance, and the muscle becomes prominent. Trapezius is tested by asking the patient to shrug the shoulder. It can be tested in 2 sites separately. So last one. So 12th nerve, it's the tongue movement that is usually tested. There are different sets of muscles in tongue. There are the longitude muscles, and there are vertical muscles also. Okay, so each half of the tongue is supplied by a separate nerve. So the tongue protrusion, the lateral movements, and retraction, all are mediated by the 12th nerve, the hypoglossal nerve. So if there is a 12th nerve palsy in the right side, when the tongue is protruded, the deviation will be towards
Left.
and when the tongue is retracted, deviation will be towards so palsy is in the right side. Anything seen? It's actually an MRI scan. Anyway, there's a pointer here. So this is the base of skull. Very good. There's an atrophy seen. So this part is atrophic. So there's a 12th nerve palsy here. So that part of the tongue is atrophic. Okay. So the genioglossus pushes the tongue forward. So it's pushed from the right side and from the left side. It's sort of balanced. So when there's a palsy in the right side, when the tongue is protruded,
Move to left. Opposite.
tongue gets pushed to the right side. So tongue gets pushed to the right side. And then what happens when the tongue is retracted? So when the tongue is retracted, the longitudinal muscles of the tongue are important. So these ones. So the longitudinal muscles in the left, we are talking about the weakness of the right side. The longitudinal muscles in the right side are already weak. So when the tongue is retracted, tongue deviates towards the left side. So you get confused unless you are aware of this. So pushing will be towards the side of lesion, but in neutral position or in retracted position, tongue deviates to the other side. So that is something about the, so tongue, you will be asking the patient to protrude the tongue and then push against the cheek and you apply pressure. So in certain situations, tongue will be spastic, as in ALS, amyotrophic lateral sclerosis, where you may have to palpate the tongue. So in ALS, basically, part of the tongue will be spastic and part of it will be atrophic. So when you palpate, you can see the atrophic part as well as the spastic part. And you are getting atrophy and spasticity side by side is almost diagnostic of ALS. Similarly, you will be getting fasciculation in the atrophic part of the tongue. So that is about the cranial nerve examination. One or two cases, this is actually, it will be difficult to read from there. This shows various combination of cranial nerves, which helps us in making diagnosis. This is usually in brainstem lesions. So in midbrain itself, you can have a third nerve palsy with a red nucleus involvement, where there will be ataxia. You can have a third nerve palsy with a crus cerebri involvement, when you had a hemiplegia, like that. So each one has different names. In the pre-MRI era, this chart was very useful. So we just pick up the cranial nerves involved and try to place it in one of those. And some of them will tell us the vascular territory also. So this is not that important now, because one imaging is going to tell us most of the things. But it's nevertheless easy to convey things if you use these words as syndromes. This is a problem, madam can help me. So he is having he said he has double vision. And his main issue is he's having problem in driving. So it's something that is disabling him. So which is the muscle that is involved? Is it precisely another assumption? So I think it's from precise only. Is there anything seen? Correct. My God. Yes. So here it's actually no, it's a vertical separation, no? The color has not come out well. No, one is red and one is green. Actually, the upper part is green. This is green and this is red.
His history was he was worsening and then he started improving.
Exactly.
Phobia was starting was done when he was improving.
After 3 months, no?
Then
This
again
one.
he came back, he said he's again worsening.
So this is the second one.
No, there's the second one with the separate, yeah.
This is the
That's
second one, no?
Yeah.
So he has improved or he has worsened?
He's worsened.
But these lines are overlapping. That is what was interesting. So the vertical separation.
Not with separation of images. Here we can actually see the separation of images on dextroelevation and dextroversion. The second one.
Here,
There was
There-
vertical diplopia for sure.
there is no overlap here. That's the interesting part. There is no overlap. This line and this line are just touching. Okay, so he came to me also saying that he didn't have improvement. But then on close analysis, see the overlap has increased, which means that but for this one, it was, so I managed to send him off without doing too much. So he had an MRI done already. So next I had to decide on whether I should do a CSF study or not.
Because of the fleeting, like fleeting symptoms, it was on and off, so I was thinking whether we should be investigating in terms of some vasculitis or some kind of demyelinating disorder.
Demyelination, we have done an MRI already. Vasculitis, we'll have to do a CSF study.
Myasthenia is a cause of doctor myasthenia.
No diurnal
Because it can vary, like anytime, sometimes it's already
But
weird.
see, this is purely vertical. There is no other separation. And it's consistent. Taken 3 months apart without any treatment, the pattern is essentially the same. Except that there is some overlap here and there is a separation just in one. Okay, anyway, I have decided that I want to do anything now. He'll come back after 3 months.
Can you tell us what it was?
5 minutes, sir?
What was it?
No, we don't know. It's a vertical problem. One of the muscles which move the eyeball vertically is having a problem. No, the point which I was trying to show is, he came, first he came and this was diplopia darting. So this is one and this other one. The overlap was not too much. So after 3 months, he was confused as to whether he is really worsening or not. If he is worsening, then we'll have to go for next set of investigation.
When was the diplopia starting taken? One in the morning, one in the evening, like that?
both in the morning.
He was still stuck with myasthenia gravis.
No,
No.
because they can see in the evening, compensatory mechanisms of the eye can become very weak.
Exactly.
So it's
That's
very
it.
important that we know that, and many times congenital oblique palsies, when they are compensated,
Okay.
you cannot really make out because they will have a lot of compensatory mechanisms occurring over a period of time.
Okay, sir.
From birth, if you have an oblique palsy, over a period of time, they can look like this also. Like
Maybe, okay.
so
Yeah, his symptoms are of recent onset, maybe a few months. Okay. So
Which
we'll
side?
come
Which
to-
side? Which side?
Which one, sir?
Which side? Right, left? Which
It's
side?
difficult to say. Okay, now this one. What's the abnormality?
right subcutaneous oblique palsy.
Okay, so this is a lesion. It was a meningioma.
Where? Location?
Meningioma, it was in the sphenoid apex, intracranially. Okay. Wrinkles are prominent. So wrinkles are prominent means he has bilateral ptosis. It's prominent both sides. Okay. Now, this is down and this is up. And the wrinkles are prominent. Now he's looking up. So this comes stops here. Up and towards the left side. And he looking towards the right side. So both eyes are involved. And all the nerves appear involved. And there is prominent. If the wrinkling was absent, then it's easily myasthenia gravis. But even if it's present also, so the involvement doesn't fit in with any specific nerve. Any specific of the 3 nerves, we can't fit it with any of them. So by looking at the picture, even without looking for fatigability, this gives a clue that it's myasthenia gravis. So you can make the patient fix on an object which is up and hold the eye like that for say 2 minutes. So that is how you look for fatigability of the eyelids. So slowly the eyelids will come down. So if the patient is able to hold for more than 2 minutes, then usually fatigability is not there. Similarly, you can ask the patient to abduct the arm also and keep it for 2 minutes. Another way will be to ask the patient to move the limbs up and down, say 10 times, and then check for the proximal power.
So what is the test for ocular myasthenia that we do to confirm before we start treatment?
Investigation of choice will be nerve conduction study. Actually, single fiber EMG is the best one, which is not done anywhere here. Otherwise, it's the nerve conduction study. Now, if you are talking about ocular myasthenia gravis, there is no hurry in starting. We can wait for the, because it doesn't have any major implications. We'll wait, do investigation. If it's not conclusive, we can still wait. Or alternatively, you can directly go for the Tensilon test. You are giving the injection, and if the patient improves, then you can directly start the treatment. A still similar way will be go for treatment.
Ice pack test.
Acetylcholine receptor antibody will be positive in 80%, and anti-musk antibody is positive in another 20%. Gold standard is probably RNS, so that demonstrates the neuromuscular junction abnormality, and this gives a clue as regards the etiology. But for ocular, we are never in a hurry because we may not go for immunomodulation. But if you are thinking of systemic, then it's very important. We have to make an early diagnosis. And all these things will be acetylcholine receptor antibody, and we do the imaging of the chest to look for thymus. Some of them can be having thymic hyperplasia or thymoma, in which case we advise surgery. So here,
What was that case, previous one?
that's myasthenia gravis.
No, but the frowning was there.
That was the confirmed. Frowning was there. He is having ptosis bilaterally. So to compensate for that, he is frowning. But if the frowning was absent, then it would have been easy for us to diagnose. But still, because the ocular movements are very erratic, doesn't fit with any specific nerve involvement. So that gives a clue.
But that also you could have tried repetitive movements and see whether the frowning fails.
Okay, sir. Sir is a cardiologist who always wonders the neurologist by his presence and questions and answers. Titles are similar to all of you, I suppose. He's professor of cardiology. He was in Sri Chitra, and now he is in Cosmopolitan Hospital. And he is cosmopolitan in his presence in any CMEs. At least whichever I have attended, I have seen, sir. And I always enjoy your questions, sir. So this is a ice pack test. So there is bilateral doses. So ice pack is kept here. And immediately after removing the ice pack, the eyes are open. So this was closed like this. So after the ice pack, it's open. And again, after some time, the doses is setting in. So this is a good test for myasthenia gravis. This is again myasthenia gravis. So this is a specific sign. I've asked the patient to close the eye tight, screw tight. So he's doing that. Here also he is doing that. So what's that? Peaking sign. It's peaking sign. So after closing for some time, the eyelids are fatigued, so it's opening and he is peeking through it. So these are some of the specific signs. Very often we get reference from the ophthalmologist suspecting myasthenia gravis. So pupils should be normal. That's one thing. And tests of fatigability should be there. But there are situations where it's very difficult to diagnose. You don't get tests of fatigability, and the nerve conduction study also may not pick it up always. But as long as it's confined to the eyes, we can wait. Only thing is we are worried whether we are missing on something else, whether we should go for imaging and all. So ultimately, we end up doing an imaging, but not beyond that. So invasive like CSF study and all, we don't usually do. We are able to manage without doing it in many of the situations. So 45-year-old lady was a diabetic. She had a right facial pain of 1 month duration. On examination, she had a right third and sixth nerve palsy. Pain was very severe. It's an excruciating, continuous pain. And the MRI of the brain was normal. And the CSF also was normal. Only 45 years.
Diabetic mononeuropathies can have extreme pain.
This is not mononeuropathy. 3 and 6 is involved. 1 month pain. Mononeuropathy, some pain can
Severe
occur.
painful,
May not be severe, sir. Mostly it's some pain in the background like that. So patient was given steroids and patient made a good recovery. So
Polyneuritis cranialis.
this is a Towers-Hand syndrome. So multiple cranial nerves and no structural abnormality, no obvious inflammation and responding steadily to steroids. So this is a 65-year-old lady with a headache of 2 months duration, visual loss left eye 1 month, and on examination right third no palsy, and ESR is high. MRI is normal. CSF not done. So temporal arteries were tender also. So it's tonsil arteritis. That's all. I'll just show 1 or 2 videos and I'll wind up. And so now we can see that. That's all. So what's it? That won't be so fast. So actually, it's a very fast movement, circuits at the best possible velocity in all directions. It's irregular. I would say it's chaotic. So chaotic, multi-planar movement of the eye. So this is called ocular myoclonus. Ocular myoclonus. So he had other myoclonus also. So the exact term is opsoclonus. So very chaotic one. So when he was made to sit, he was having myoclonic jerks. So it's a truncal myoclonus. So it's called opsoclonus myoclonus syndrome, and usually it occurs in brainstem viral infections, brainstem encephalitis, or it can occur as a paraneoplastic manifestation. It's again on nystagmus. So she is looking towards the right and she is having coarse nystagmus towards the right. Now she is looking towards the left. Any thoughts? Okay, so little more I'll explain. So when she looks towards the left side, it's fine. It's not very coarse. The amplitude is less. And fast component is towards the left side. So when she looks towards the right, the amplitude is more. So it's coarse. And fast component is towards the right side. Any clues? So actually she has 2 different types of nystagmus. In that case it will be coarse in both directions. So the nystagmus towards the right side is a coarse one, so that's a cerebellar nystagmus. The one towards the left side is a fine one, so it's a vestibular nystagmus. Now, when she looks towards the left side, the fast component is towards the left side. In a vestibular nystagmus, the fast component will be away from the side of lesion. So if you analyze the nystagmus towards the left side, it's a vestibular one, so there's a vestibular lesion in the right side. Now, if you analyze the cerebellar nystagmus in the right side, when she looks towards the right side, it's more on the, its course on looking towards the right side. So, cerebellar, the direction doesn't really give us a localization, it keeps on changing. So, but the vestibular is from the right side. So, there is a lesion which is producing, it's a vestibular lesion.
CPM.
Very good. So, and so this is called a Brunt's nystagmus. So Brunt's nystagmus pins down the lesion to CP angle. So you can't get this combination otherwise. I think that's the last one.
What about the corneal reflex?
Sir,
Corneal reflex will be absent with the CP angle.
when it's more than 5 centimeters, when the size is increased, usually 5 is kept as a cutoff, then it can be. It involves the fifth nerve also, then the sensation can go. That's the last one. Once again, thank you very much for very active participation and giving me this honor of presenting you.
Sir, a doubt. Prabhakaran's criteria പറയുന്നത് granulomatous inflammation of governance and superior fish not demonstrated by MRI or biopsy.
അങ്ങനെ പറയുന്നുണ്ടോ? ശരി. അപ്പൊ MRI യിൽ കണ്ടില്ല. CSF was normal and patient responded to steroid.
ഇത് both
ഇത് ഏത് criteria?
Sir, the ICHD3 diagnostic criteria.
ഇതിലേക്ക് ഇല്ല അതിനകത്ത് വരുന്നല്ലേ?
American Academy IVK സൈറ്റിൽ granulomatous inflammation.
ഗ്രാനുലർ കിട്ടുകയാണെങ്കിൽ CC ഫസ്റ്റ് ഡയഗ്നോസ്. കിട്ടില്ലെങ്കിൽ എന്ത് ചെയ്യും?
പക്ഷെ ഇത് both of the following ഇത് mandatory ആയിട്ട് പറയും.
അപ്പോൾ this could be something else. I surrender.
The cranial polyneuritis will have an abdominal CSF.
Pardon me, sir?
Polyneuritis cranialis will have an abdominal CSF.
No, we don't have a
So
abdominal.
then this can be that.
But it's contiguous. So this, when 3 and 6 is involved in the same side.
7 also.
No, for this patient,
3 and also.
only 3 and 6. Only 3 and 6. So it's localized to orbital apex or governor sinus. So it's not separate. It can still be, but we always try to localize to a single area.
Another possibility is both of them orbital inflammation, pseudoclinical
Again, probably
myositis. What is the patient pain?
That's what.
There's no granulomatous inflammation at the orbital inflammation. But usually only one nerve is easily, one muscle is easily affected, third and sixth nerve is affected.
Yeah, unusual.
And a facial pain, 7th level, facial pain.
Facial pain was there. So that localizes to the governor sinus. So 3, 6 and 5 means it will be governor sinus usually or orbital apex. That's superior orbital fissure. Area.
We see a lot of patients with essential blepharospasm. And many patients, they have like oculomotor apraxia like features, like, you know. So we don't have anything to offer them. We don't do botulinum toxin or anything, we don't do. So what is the?
Botulinum toxin is given very widely now. It is
Neurologist are using. Neurologist are
it
using.
is Sreethal, it was regularly being given. But a lot of people have started giving. The only problem in giving is there are two things. One, if you don't give the adequate dose, you don't get the result. So money is lost. If you give too much of dose, then there will be doses. Then again you get hit. But otherwise, blepharospasm is one condition where the botulinum toxin can really make a difference. I think share maybe 10,000 for one sitting. And one sitting can go on for 3 or 4 months. So short of that, we can try hexaconidine or chromazepam. Some of them may respond to baclofen. So different we can try. But this is the best one. Toxin is the best one. It's available.
How do you diagnose occipital blindness?
Which one is the hospital?
Blindness. Occipital blindness, how do you diagnose?
Usually it is diagnosed by imaging only. But then in some dementia situations,
because of selective posterior cortical involvement, it will be diagnosed just based on the symptoms. We can't do any specific investigations.
Pupil will be normal and also.
For all cortical blindness,
Pupil will be
people
normal.
will be normal.
That is one important.
If it's bilateral, usually it will be picked up by MRI, but in certain degenerative conditions, it won't be picked up by MRI. Then it will be just a clinical diagnosis.
Features like visual hallucinations and right leg disorientation.
Right left disorientation sets in only when the parietal lobes in. When it's confined to occipital, it will be there. That won't be there.
Severe visual loss. Severe visual loss.
And they can be, they can have denial of, and they will hit against objects, but they give excuses for, they give some other reason. They never say that they are blind. Thank you once again.
Thank you, sir, for the wonderful talk.
How do you differentiate papillary edema from hypertension and intracranial tension? Because you showed papillary edema due to IC.
In malignant hypertension also, you get changes more or less similar to papillary edema. But then we look for other features
Blood
also.
pressure. That's the only way.
Blood
Pressure
pressure.
can also contribute to
No, it can go the other way. Like when the intracranial pressure is increased, blood pressure can go up. So that doesn't always help you.
No, but not to that high levels.
It can go.
Malignant hypertension.
One is that? Malignant, but it can go that way also. But then other features like headache, sixth nerve palsy if it is present, some clues we may get as regards in raised ICP. But in some situations it will be difficult also.
Actually, when you examine, papillary edema is gradually, if it is not because of hypertension, it's a very gradual process. You see just this edema goes through various stages. In malignant hypertension, you see cortical spots, you see a macular star, nasal macular star, a lot of other features, retinal features you see.
Retinal features.
That is very important. Papillary edema goes through stages, like initial there will be a papillary edema, then goes to chronic, optic atrophy, like that. You will not see a lot of hemorrhages, hard exudates. Those things you don't see in tumor-related papillary edema. But you see in malignant hypertension, all these features, what is macular star, flame-shaped hemorrhages, cortical spots, features of hypertensive retinopathy, you will be able to see. So that is one important.
Accelerated hypertension, sometimes you get without first aid.
No, what I'm saying is
Yeah,
basically,
that is good.
So when the patient comes, we measure BP. If it's high, you say that it's papillary edema. You ask them to control BP, and you call them after 3 weeks. If it is because of hypertension, it will
No.
Secondary hypertension.
May be dangerous. He may be coning also. You will have to go for image. It will be difficult if you are seeing florid papillary edema with high blood pressure. Better that you do imaging and make sure that you are not missing a tumor or something. Venous thrombus and a lot of situations where you develop papillary edema very rapidly, and they can deteriorate also.
Thank you, sir, for that very wonderful, interesting presentation. Question answer session. Anything? Anybody's having any more questions?
Pediatric questions they come.
in congenital oblique palsies, how does the spread of commutants occur? Like many patients have, finally you see the ischial muscle is not the.
Not the, usually underaction or overaction of the complex synthesis.
So the case that earlier that was shown, it could be a spread of commutants of an oblique palsy.
Decompensated congenital oblique palsy, because that was not fitting into any pattern in the path which was used.
What is the percentage of squint patients who go for surgery? Because in Madurai, Dr. Tyagarajan used to do a lot of when I was there,
Yeah.
squint surgeries.
Sir, actually,
Squint surgery indication, as I told you, is whenever there is any risk of amblyopia. It cannot be corrected by glasses, when it's a constant squint and there is a risk of amblyopia. And second thing is when there is whenever there is a chance of regaining binocular single vision, like in case of a congenital esotropia where there is chance of giving the child and good binocular single vision, good stereopsis, better to do the surgery early. And then whenever in large angle exotropias, when the children have a difficulty in like asthenopic symptoms, they're not able to study well, it affects their scholastic performance, it's an indication for doing skin surgery. Diplopia, of course, sometimes we may need to resort to surgery in case of diplopia. Then, of course, the cosmetic aspect is the predominant factor, I feel, more than anything else, which warrants surgery if the vision is equal in both eyes, there's no risk of amblyopia, alternating fixation. So these are the few indications. Whenever it's not corrected by other measures, we resort to surgery.
And you said genetic, what is the mode of inheritance? Is it
It's
autosomal or
unknown,
recessive?
it's actually not clearly proven as to what exactly the mechanism is, but there's definitely a hereditary pattern which happens. So whenever we ask for a family history, more than 50% we get a positive family history.
One important point is like, this Duane's contraction syndrome can mimic lateral palsy. Many times, we diagnose lateral palsy, sent to they say Duane's and send back.
I actually have highlighted that. I've shown 2-3 pictures showing how you need to look at the ocular movements completely and look for any retraction of the globe or narrowing of the palpebral fissure on the
So any more questions?
Like optic neuritis, many times whenever we give IVF, we get a real response after your 5 doses and the short course of tapering. 2 weeks, 11 days taper. 3 days steroid says 3 days IVFB and 11 days you taper steroids and stop. So what do we do for the patient? How do we manage? You should investigate more because optic neuritis, there are a lot of other causes, new causes are coming. So how do you go about it?
So practically, we stop at that level. We do some baseline, something for vasculitis, like we do some ANA, rheumatoid factor, SPSAB, some factor of which are known as a screening for vasculitis. And we stop there.
How much interference?
Interferons are basically for prophylaxis in RRMS. No, it's not for acute treatment. No, you have diagnosed multiple sclerosis and you are sure that it is RRMS, then you go for interferons. Now there are orals. So we prefer that. Otherwise, but we see both.
There's some new, like granulocytes, some dendritic, some positive optic neuritis, transverse myelitis with optic. There are some entities which are beyond our usual this thing. Like because we see a lot of optic neuritis, they don't resolve. You can still see optic nerve edema over a long period of time, and it's a position where we cannot continue steroids.
You are talking about NMO.
NMO spectrum.
NMO spectrum, if you diagnose it, then you do antibody study for that. And if you diagnose it, then we go for more stronger immunomodulation. Like we can go for plasminogen and the newer ones and rituximab. So that is there, but you have to diagnose NMO spectrum by antibody study. So usually there should be some element of myelitis to really diagnose. It's neuromyelitis optica. So generally it becomes a malignant entity. And there are visual loss, it doesn't recover well with steroids. Then we go for different types of
I think as ophthalmologists we just give steroids after 11 days we stop. There are a lot of things we are missing. Like this kind of things, because all patients cannot be a straightforward case of.
If the patient doesn't improve, but even otherwise, optic neuritis means imaging is mandatory. You should not be missing a usual multiple sclerosis. So one step more you have to do whether patient improves or not. Setting off without doing MRI may not be.
No, but I think
Now it's widely available and
for-
you can
No,
say 10-20% may be a must.
no, I think follow-up is important because of the relapses and remissions. That is
No, sir,
important.
when they come with a relapse, then it's easy for you. So to optic neuritis means we are already in the track of thinking about MS. But to pick it up in the first instance itself, we'll have to go for some experiments.
NMO has got to be with Crohn's or anything like that. Crohn's or innovation or NMO with Crohn's.
I think you have to look at
NMO is
the,
I don't know whether it's a.
no, I think NMO you have to look for the anti-aquaporin antibody.
Anti-aquaporin. So it's bilateral usually.
Now I would like to invite Dr. Jairam sir to give a memento to Dr. Robert Mathew sir. I would like to invite Dr. Ashok Natarajan sir to give a memento to Anitha madam.
I'm a family member, so.
Now I want to invite General Manager of Precise Specialty Eye Care, Mr. Sharad, to give vote of thanks.
Good evening to all of you. It gives me an immense pleasure to deliver vote of thanks on this occasion on behalf of Precise Eye Care. Firstly, a special thanks to our chief guest, Dr. Robert Mathew, who delivered a presentation here. Secondly, vote of thanks to our own consultant, Dr. Anitha Prabhakaran, who delivered a good session here. Also, thirdly, my vote of thanks to our all guests who gathered here today. And lastly, our thanks to our chairman, Dr. Jairam, who supported this event, this series of CME to a big success. Thanks. Sorry. Now I request all of you to come for dinner.
Sponsors. No sponsors.
Yes, sir. You are correct. Sponsor of this program is Lupin Private Limited. Thanks.
Thank you.